Hey, what's up, guys? This is Islam speaking, and today I'm going to talk to you about an introduction of what is the electrophysiological findings in the polyneuropathy and how we can use these findings to narrow down the possibilities of the polyneuropathy. At first, I'm a nerve testing and electromyogram resident here in New York, and I'm also a neurology fellow. And just for you to know, this video is just for educational purposes. And today I'm not here to talk about how to test for polyneuropathy, because I know that probably most of EMG specialists know how to do that. But the main reason why I'm doing this video is we try to look at polyneuropathy from different perspective. And how to use the EMG results to try to narrow down the possible causes of the polyneuropathy. And just first, a very quick definition that a polyneuropathy is a nerve damage or infarction due to an attack that happened from a systemic pathogen. And just to put things straight, that as long as this pathogen is left unrecognized, the patients will keep getting worse and the nerves will keep dying, because the first line, or maybe the only line in my opinion, to treat the polyneuropathy is to stop these pathogen from attacking the nerves. And you will never be able to stop the pathogen from attacking the nerves if you don't know what is the pathogen. And I think if you're able to do that, first step to diagnose the pathogen, step number 2 is to give the appropriate medication to stop these attacks. Like, it's a 2-step process. Step number 1 to diagnose it. Step number 2 is just to give the medication, the treatment, to stop the attack of this polyneuropathy or the pathogen that's leading to the polyneuropathy. I think the nervous system has the capacity to regenerate itself eventually. You don't need even to give whatever intervention, or any intervention that you will give to the patient will just accelerate the process. And of course, it depends on when you diagnose the patient and what's the diagnosis. And I know the most important or the most challenging thing for most EMG specialists is the 1 million possible causes of polyneuropathy. There's a lot of causes of neuropathy, from endocrine to deficiencies to metabolic causes, toxins, infections. So what I'm going to do today is I'm going to give you some information on how to narrow down the possibilities, so you're able to know what is the pathogen. And there's a lot of research articles that done to try to narrow down the possibilities until David Person and Shapiro in 2005, and their fantastic publication, they try to find some solutions. And I know that the general agreement is saying that it cannot tell you like specifically what is the cause of polyneuropathy, but until now textbooks are giving us some clues that we can use from the EMG results to understand what is the polyneuropathy, and this is what I'm going to show to you today. And again, the results is really dependent on when you find the disease, when you diagnose the disease, and what is the cause of the problem. So the first clue, the first piece of information that can help you to really know what is the cause of the polyneuropathy is the temporal course of the patient. Whether it is an acute polyneuropathy, or it's an on and off, relapsing, remitting, or it's a chronic polyneuropathy. Today I'm going to start with the acute polyneuropathy, and just for you to know, especially if you work in a hospital setting, you know what I'm talking about. So an acute polyneuropathy, it is the patient usually comes in, he was absolutely normal with any previous problem or issues, and in a matter of days to weeks, the patient starts to develop a rapid onset progressive paralysis and weakness. And it can hit in any age. It's not dependent on the age of the patient. For example, the next picture, you will see a child. The usual thing is the patient sometimes in a matter of days to weeks lose the ability to breathe on their own, so they had to be on a ventilator. And there's a rapid onset progressive paralysis affecting both upper and lower extremities in most cases. And the ER do the usual diagnostic procedures to rule out stroke, and it comes back negative. Now they are doing the neurodiagnostic examination. If it is this scenario, if it is an acute polyneuropathy, you can narrow down the 1 million causes of polyneuropathy into just 6. Number one is medication, and I'm sorry. So number one is medication, and the top of there are like mainly 3 group of medications that I usually see in my patients. It is the antibiotics, antiretrovirals, or chemotherapy. So if the patient was absolutely normal for a long period of time and then they developed a pneumonia, for example, or whatever, they needed to start taking antibiotics, and then they started to develop a rapid onset progressive paralysis, that's a very strong evidence that the polyneuropathy may be related to the antibiotic that they took, that especially if it's shortly after they start taking the medication, they start to develop the polyneuropathy symptoms, and especially it's confirmed with the EMG results. Also, the antiretrovirals, HIV medications are on the top, and chemotherapy, of course. This is scenario number one. Scenario number two, that you come to the ICU, you do the EMG, and you find a presentation of pulmonary neuropathy multiplex. If you find that presentation and the patient has a history of a vasculitis, that's a very high possibility that the patient is developing an exacerbation or an attack of vasculitic neuropathy. I know that in most cases, you will see vasculitic neuropathy as a part of the chronic condition, as a chronic polyneuropathy, not an acute. But I personally saw, and there's a lot of piece of evidence in the textbooks talking about an attack of vasculitis that is associated with a vasculitic neuropathy, and it usually presents itself as a pulmonary neuropathy multiplex presentation in the EMG results. Toxins are also there, especially if the patients have travel outside the country. Infection, including Guillain-Barré syndrome, which has a very specific presentation in EMG results, tick paralysis, and diphtheria, especially in unvaccinated children. So this is one of the things that I ask if the patient is in the ICU and he's kind of maybe especially from the child from outside the country and they're not vaccinated. Diphtheria is one of the things on the table. Genetics, especially if the patient is developing skin lesions with the polyneuropathy, that's a very strong evidence that maybe porphyria. But again, not all porphyria is genetics, because you know that there's an acquired cases of porphyria where it's come from physical or psychological stress, alcohol, or smoking. Of course, exacerbation from an AIDP, acute inflammatory demyelinating polyneuropathy, can be the cause of the acute polyneuropathy. So you see it now, right? That just because you know the temporal course of the polyneuropathy, you can narrow down the polyneuropathy in just six groups from 1 million causes or that can lead to the polyneuropathy. And basically the second factor that you can use, or the second thing that you can think about when it comes to narrowing down the possibilities of polyneuropathy, is the symptoms. And that is really connected to which nerve fibers are affected. Meaning, you have to be familiar with this classification if you're going to work in EMG, because you have to understand that the size classification of the nerves, that all the nerves are large, categorized into either large or small. All the motor fibers are large, and all the sensory fibers and all the autonomic fibers are small, and the sensory fibers are in the middle. Some of them are large and some of them are small. The large sensory fibers are responsible for transmission of joint sense and vibration, proprioception, and the small sensory fibers are the pain and temperature. They're responsible for transmission of pain and temperature. And as you know, that the EMG can only record the fastest nerve fibers. So actually, EMG only pick up the signals from the large myelinated fibers, or the motor fibers, or the sensory fibers when it comes to EMG. So basically, these are the two types of fibers in the human body. Either the nerve fibers are really large or small. The large fibers all the time are motor. Small fibers all the time are autonomic. And when it comes to sensory, they are both in between. There's a small sensory fibers responsible for transmission of pain and temperature, and there is also a small sensory fiber responsible for transmission of proprioception sensation. So how that's connected to polyneuropathy? Now, all polyneuropathies, or most polyneuropathies, will affect both fibers, small fibers and large fibers. But the key here is, if the patient's symptoms and nerve testing results are consistent with either the affection in only the small fibers or only the large fibers, then will give you a very important piece of information that you can categorize and narrow down the possible causes of polyneuropathy. Meaning there is an only large fibers polyneuropathy, and there is only a small fibers polyneuropathy. I know that the majority is affecting both of them, but when the patient is developing just one of these two, this will help you a lot to narrow down the possible causes into just two categories. So how to know from the patient's symptoms? So as I said, if it is only a small fibers polyneuropathy, the patient will have autonomic symptoms, arrhythmias, hypertension. Both are possible depending on the theoretical and positive and negative symptom manifestation theory, and we can talk about that in future videos. But yes, the patient can present with a hypertension or hypotension, diaphoresis, arrhythmias, urinary retention or impotence. If it is a small fiber, it's going to be affecting the autonomic fibers, and the small part of the sensory fibers, which is responsible for the transmission of the pain and temperature. So they're going to be a decrease in pain and temperature sensation, and instead there will be a burning and shooting because the pain and temperature sensory fibers are damaged. If it is a large fiber polyneuropathy, so the patient will come with a motor symptoms, fatigue, cramps, myochemic discharges, weakness or fatigue, and orthopedic manifestations, including pes cavus, and have large fibers of the sensory nerves manifestations, including loss of joint sensation or like ataxia. If this is the case, so now you can narrow down the possible causes of polyneuropathy just in two groups. If it is a large fiber neuropathy, then it's 100% going to be just in this list, either lead poisoning, porphyria, GPS, genetics, as we said, you're married to polyneuropathy, for example. Or if it is a small fiber neuropathy, which of course you understand that if this is a scenario, the EMG results will be 100% normal because the EMG will never be able to pick up the signals from the small fibers neuropathy. So in this case, the patient will have an autonomic symptoms that we just talked about now, and pins and needles, because the small fibers are damaged. The small fibers of the sensory nerves are damaged, so the patient have burning and shooting in conjunction with the autonomic the manifestations. If this is the case, if the patient is having all of these symptoms and normal EMG, these two together, so there's a very strong evidence that the patient may be developing a diabetic neuropathy, some cases of diabetic neuropathy. We'll talk about diabetic neuropathy in a separate video because it's obviously a very big topic. Or amyloidosis comes now, or an HIV neuropathy, or a hypertriglyceridemia. So now you know, right, that now when you just know what type of what's the symptoms of the patient, you can narrow down the list of 1 million causes of polyneuropathy into just a very few. So probably that's it for today, and in a future video we will keep talking about how to narrow down the possible causes of polyneuropathy. If you have any questions, just leave questions in the comment, leave me a message or comment below, and I'll get back to you. Thank you guys for watching, and have a good day.